welcome back, everyone. Now I would like to introduce our next speaker, Professor Rebecca Michel, who has joined us online. You can see her on the screen. Rebecca is a professor in organizational psychology and human resource management at Macquarie University. Rebecca leads the Health and Wellbeing Research Unit at Macquarie University, which brings together scholars from a wide range of health, psychology, and business disciplines in research on health and well-being at work. In addition to her academic experience, Dr. Rebecca has worked as a state representative on several Council of Australian governments, working parties, and has developed health, community, and social services policy at a state and national level. She is an academic member of the College of Organisational Psychology. Her topic of presentation is reproductive transition and women at work. Over to you, Rebecca.
Just wanted to say, first of all, thank you so much for involving me in this. It's just such a fantastic idea. I really appreciate it. You know, part of me says about time, and part of me just is so happy that somebody like yourself, Man, and Path have done this. It's just wonderful. So the intention of my presentation is to overview not just one particular aspect of women's reproductive related health, but to sort of try and provide an overview that highlights the fact that women, from the time they start work through to the time they finish work, really have quite a lot of reproduction related issues that emerge that they have to deal with, some of which are very poorly researched. While they may be researched well clinically, are very poorly researched in terms of women's experiences at work and workplace capacity to respond. So the way I've put this together is, as you can see in this slide, the four M's being menstruation, maternity, motherhood, and menopause. Quite a few people ask me why I separated maternity and motherhood. And of course, that's because people can become parents without actually going through a pregnancy, should they choose to adopt. And sadly, because people can go through pregnancies without becoming parents. And the two experiences are quite different for women. So the first M is, I think this will work, yes, is menstruation. And then I'll continue through longitudinally, but obviously some of the concepts that we talk about might be more closely related. For example, menstruation and menopause are often hormonally similar in some ways in terms of the way in which estrogen and progesterone are opposed. So there is, even though I've talked about it in a longitudinal way, we know that there are similarities and connections. It's not a linear process for women. So just moving through to menstruation. First of all, I think it's quite interesting to think about menstruation in terms of what we call premenstrual syndrome. As I was preparing for this, I was writing a paper and I was also preparing for this. It struck me that almost 90% of women report experiencing some sort of premenstrual syndrome at some point. And so that means characterized by things like by physical symptoms as well as emotional symptoms, including things like dysmenorrhea, so pelvic pain, which is somewhat debilitating for about 15%. But if we go back to the 90%, I think, you know, for me, I would see that as something that is quite universal then, that experience. And therefore something that we perhaps shouldn't see as an issue relating to just a few women, but something that is part of the way in which women often experience menstruation with significant symptoms causing quite distressful situations at work. Much of the research in the area is related to, as you would expect, organisational consequences. And some of that recent research suggests that it's 2 billion roughly annually lost to missed work due to menstrual related pain and symptoms. So when we try and connect that to women's experience, it seems that women are likely to take leave only when there is the more severe symptoms, which indicates to us just how much this is impacting women's lives. Part of what I wanted to draw attention to here, and which I have seen in a lot of the existing presentations, is the separation of the reality that women experience in terms of their physical and emotional and cognitive and symptoms, and the impact of stereotypical and beliefs and stigmatization. So while with menstruation, for example, we can see that there are significant physical and emotional symptoms, there are also stereotypical beliefs that are related to menstrual-related negative mood, decreased competence, and these can amplify what is already existing gender stereotyping. And we know that this has negative impacts on recruitment decisions. And I think we heard a wonderful description by Mary Cook about the decision of the ANZET decision. We like to think that's an historical decision, but unfortunately it isn't, and it's very much alive and well. There's very little research actually linking menstruation with cyclic deficits in cognitive or social functioning, but stereotypes and stereotype threat leads women to perform poorly in experimental tasks. So stereotypical beliefs may actually precipitate responses in terms of the way in which women perform at work. We also have menstruation-related challenges. Typically, people often think about endometriosis, and probably that's because it does affect 10% of women. So 1 in 10 women, it's a very high proportion of women who are affected, given they have very debilitating symptoms. And those symptoms range right through from bowel, bladder, abdominal, infertility, psychological distress, very significant. And that can severely, obviously, disrupt their work capacity. But once again, it's very hidden. People feel as though there's a strong stigma, and there is a strong stigma around menstruation-related challenges, including things like endometriosis. So I think it's probably worthwhile thinking about disclosure and the way in which women react to interact with healthcare providers and HR professionals, and introduce that at this point. So when we have a situation where we have physical and cognitive challenges, and we also have an awareness of stereotyping, so that meta-stereotyping is very common. We did quite a lot of research in the area of menopause, and the research that we've done linked to stereotyping indicates very significant and severe stereotyping of women about women. And that includes women who are going through menopause and how they perceive that meta-stereotyping, how they think other people stereotype them. And that, of course, leads them to withhold any kind of disclosure from their supervisors or co-workers, with consequent reduction in the capacity to seek any kind of support. The same kind of experiences are true when we think about healthcare providers and HR professionals. And so that stigma is leading to a taboo, which means that women are stereotyping themselves, fearing other people are stereotyping them, and just not getting the support that they need from their supervisors and their co-workers. So I'd like to move on now to maternity. Hopefully maternity has come up on your screen. I find that maternity and motherhood have been better canvassed in the research compared to things like endometriosis, menstruation, and menopause. So most of you will be familiar with this research. There's a lot of debate on whether or not pregnancy influences women in terms of their cognition, in terms of their quality of work. And overall, my perspective is that there is very little evidence to support any suggestion that pregnancy significantly influences women's cognition. That said, women may take more sick leave, but a lot of this is because appropriate job adjustments are not available. And there is significant exposure to occupational hazards in just normal jobs that aren't designed for pregnant women. So I think there's a lot of confusion in the literature about whether or not pregnancy actually creates a situation where women are not at work as often as perhaps their supervisors may want them to be, without those supervisors taking responsibility for appropriate job adjustment. And once again, stereotyping and stigma are, to my mind, one of the significant and unresolved problems that occur for pregnant women. So interesting studies done 2022, 2023, so very recent studies suggesting that women go push themselves towards exhaustion trying to retain the professional image that they've developed pre-pregnancy. So these are very significant issues for women, simply largely unrelated to any kinds of changes that they experience through pregnancy, but related very strongly to their fear of stereotyping and stigmatization. Especially as women are getting older, when they decide to have children and they are moving towards leadership positions, a lot of those very strong negative stereotypes are related to women having increased warmth but decreased competence, which is linked to negative leadership and leadership-related performance evaluations. So part of not only does this affect the way in which women are treated by their supervisor, but it also precipitates depression. And just recently there was a wonderful study actually that suggests that, it's a very sad study, that suggests that perceived discrimination associated with pregnancy-related stereotypes actually has negative health implications for newborn babies. Whereas supervisor and co-worker support mitigates that stress and reduces the likelihood of those significant negative implications. But of course, as we mentioned earlier, one of the things that happens with stigmatization and fear of stereotyping is that people are less likely to engage their supervisor and discuss any symptoms that they believe are going to exacerbate that kind of stereotyping and stigmatization. At this point, it is interesting to note that if people decide not to have children, they still have that, risk associated with stereotyping. So there are social expectations regarding reproduction, and there's also an expectation that they may decide to have children later on. So they still, even women who decide not to have children or who are not pregnant, still have those kinds of stereotypes and stigmatization to cope with. So just moving on to motherhood, we've chosen to focus on a number of things here. Breastfeeding, for one, which evokes, again, stigmatization, but also in women feelings of shame and guilt. While women who do breastfeed, if they're supported, they have lower risks of depression, they have increased job satisfaction. But if they continue to breastfeed in a different kind of environment where they don't have workplace accommodations and they don't have supervisor support, they are much more likely to be depressed, much more likely to perceive work-family conflict and role overload. And we still see approximately, 10% of highly educated first-time mothers leaving the workforce. So we are still, there can be arguments around that may be a choice. That may be, are you pushed out or do you feel like you want to leave? There are plenty of arguments around that. But the research that exists in that space suggests that with workplace accommodations and supervisor support, new parents are much less likely to exit the workforce. And you think about 10% of highly educated women of an age where they're moving into leadership, it's a substantial gap that they're leaving in organisations. And for younger women, a lack of role models, which I think is something that we certainly found, particularly when we move a little bit further into menopause. Beyond breastfeeding and initial parenthood, mothers are generally viewed as less competent. They're less likely to be promoted. They're less likely to be shortlisted for new positions. A lot of that is to do with leadership. So their capacity to take on leadership roles is the stereotypes typically not seen as the type of person that should be in leadership. Ironically and sadly, the opposite is true for men. So there's a great preference for leaders with children in men. And finally, my favourite, this is work that we've been doing. So apologies if I spend more time in looking at menopause, but there's so little research here and there's such significant interest emerging, both in Australia and certainly in the US and the UK. And it is what I think it is a crisis, really. I think many of you will have read the Australian Institute of Superannuation Trustees report, where they estimate between 10 and 20% of Australian women leave work earlier than planned. And they leave work around 51 or 52 when they had planned to leave work at around 59 or 60. They interpreted that as a health crisis, which they linked to menopause, that women were leaving work due to menopause. And we can see that even though the range was 10 to 20%, and that seems like a massive range, if you have a look at work that was done just recently, for example, by the Korn Ferry Institute in the United States, they came up with I think it was 11%. There have been other research reports of more and less sort of rigor and validity, but all of these reports seem to suggest that 1 in 10 women leave work earlier than they plan to because of menopause. And that for me is so desperately sad, because at this point, around 50 years old, women are transitioning into leadership positions, and even those who are not transitioning into leadership positions have got a wealth of experience and expertise and are often standalone professionals. And losing these women means that there is such a loss of expertise and such a loss of wonderful role models for women who are coming through. So a couple of interesting kind of more or less physical points. So we probably don't realise that 10% of women reach menopause below the age of 45. So when you consider that perimenopause and menopause together that's about 7 years on average. So we count several stages, perimenopause being the lead up to menopause being the time when we are 12 months post our last period and our symptoms are starting to change. Certainly they're not always lessening, but 2 years after menopause, many women report lessening of the symptoms that they've had through perimenopause, welcoming a whole flood of new symptoms associated with being postmenopausal. So you can imagine if you reach menopause at 45, that means you will have had some significant perimenopausal symptoms throughout your late 30s and early 40s at a time when women are not expecting to have any kinds of symptoms. So one of the big issues we find is that women don't know that they're perimenopausal. They have no idea that this is what these symptoms are. They're feeling fatigued. They have a wide range of physical symptoms. We don't have the expertise in our general practitioners typically to handle these kinds of queries. And so they are really floating alone, which again, I think is very sad. We also know that 1 in 100 women are reaching natural menopause before the age of 40. So we do find situations where women are talking to us about having difficulties getting pregnant at 38 or 39, and their doctor saying to them, yes, that's because you're heading towards menopause. They find out and speak to their mothers, find out that their mothers had the same kind of thing, but this is not discussed. This is not discussed at work. This is not discussed intergenerationally. Generally, we don't know our mother's experience or how our mothers coped with menopause. Menopause has a very, very significant impact on women at work. We're only just cutting the surface of this. We know that it leads to a reduction in occupational well-being, a reduction in engagement and vitality, very negative career outcomes, increased turnover, reduced time spent in employment. And we're still not 100% sure why this is. There is a decrease in self-confidence. There is a decrease in self-efficacy. But there are also things like depersonalization that really hasn't been written too much about either in the management literature or beyond, this feeling that you just don't know yourself anymore, you're second guessing yourself all the time. Some people call it a loss of self, a massively difficult thing to deal with when you're trying to lead other people, when you're trying to make major decisions. If you've lost that sense of who you are as well as that sense of self-efficacy and self-confidence. And there's very little information there for women. So a lot of the information that is there is repetitive and very, cuts the surface perhaps only very marginally in a lot of situations. Once again, coming through to the stigmatization and stereotyping, women are very critical of their menopausal selves. They have very low self-compassion. They believe they are very embarrassed, shamed. They do not disclose their menopausal symptoms and therefore are very reluctant to ask for the accommodations that they're entitled to. And don't often receive co-worker support. Anyway, so I wanted to conclude by sort of highlighting the fact that women's experiences all run into each other. It's from the time they sort of start work to the time they leave, they have a range of reproduction-related challenges and transitions, some of which are well researched, relatively well supported and recognised in organisations, many of which are never disclosed, never discussed, very, very poorly supported. And I think it's important for us to think have women at the centre of the way in which we conduct our research rather than the issue. So we often focus on menopause, for example. We often focus on motherhood But of course, your experience of menstruation, your experience of motherhood feeds into the way in which you deal with menopause. We have people who have endometriosis and have had difficulty at work all their lives, have made sure that they prioritize their work, but sometimes that have meant, for example, as we've talked about, taking their annual leave in order to deal with their symptoms of endometriosis. And those women, just when they are starting to move away from a situation where their hormones are they're post children, they might feel as though their endometriosis is under control, and then they start to enter menopause, where they have upheavals once again and challenges once again. So it's not just women's singular experience of menopause, it's women's experience of menopause, for example, in the context of their broader experiences of menstruation, of premenstrual syndrome, of endometriosis, of pregnancy, of motherhood, and stigmatization and stereotyping that occurs at each point. So on that happy note, I wanted to say thank you very, very much for listening. It's such a wonderful opportunity to be here, and I thank you once again. Just fantastic.
Thank you, Rebecca. Please join me. So, Rebecca, we have a question from one of our online attendees. Margaret asking she has a question about, actually I read through the question. Has your research come across general research about why young and new female workers are vocally stating that they intend to retire at 45 years latest? And could this attitude have something to do with the lack of attention to this whole space?
That's a really super interesting point. And I've got to say that I don't really have any idea. I think, however, unfortunately, one of the issues that we see is that women are leaving work when they don't plan to. So they haven't set about to leave work early. They have planned to stay at work. And the fear they have of stigmatization and stereotyping, the embarrassment they feel, that inability to cope, that loss of confidence, that's what's pushing them to leave early rather than a plan to leave early. The other part of that is I'm not sure that young women are as well versed in what happens at work consequent to motherhood, consequent to menopause, as we'd like to think they are. I think a lot of the time it's not until you are a mother or you go through a period of maternity or you are menopausal that you research in those areas that you understand what is facing women.
Thank you, Rebecca. Do we have any question here? No? All good? Yes?
Yeah. Thanks so much for the presentation. I'm just wondering, sort of in terms of an awareness piece, whether it's from an organizational learning perspective or from an educational institution perspective, what can we do to inform young women, to surface the challenges that might face, because I know, having my wife gone through pregnancy, there's a lot of education in terms of the practical nature, but I think from a workplace perspective, there's almost none. She works in early childhood, where you would have thought, given the large amount of the workforce are females who would have gone through the same thing. There's really no resources, not even any guidelines of, when are you expected to return? What would return to work look like? Is there anything that, maybe the research or practically what can we do?
Thanks very much. Again, a really interesting question. I think there are a couple of ways that I want to answer that. First of all, there are resources and there has been work done, and those resources are, exist internationally as well as nationally. It is about whether or not human resource departments choose to make those available. A lot of the assumptions are that women will just do it by themselves. And part of what happens is, of course, women are are very, very good at coping. So we find that even with very difficult, debilitating symptoms, women's performance doesn't drop at work. You know, women are really good at, like your wife, coming back into the workplace. They're really good at changing their role, at managing different things. And of course, that sort of lets organisations off the hook, if you know what I mean. Women manage to do these things. They manage to cope with endometriosis and menopause. They manage to cope with pregnancy. Not only do they manage to cope with it, they hide any kind of discomfort or symptoms they have for fear of stigmatization, for fear of losing whatever professional image they had built up. So it's very difficult for this is a very difficult space, I think, because women just cope. They cope with what's going on. They make decisions. And it means that organisations aren't pressured to do what they should do, which is to make plans for return to work, to make sure that information is available, to make sure that policies are available. That are to allow women or support women to advocate for their specific accommodations. The other side of it is there's not enough funding for research in this area. Just put that plug in there. We need more.
And that is the reason we have this symposium today. Thank you, Rebecca. And there is a comment from Afruz as well in the chat. Yeah, maybe I just read through the comments. I think this is not a question, more like a comment. There is an interesting episode on ABC Catalyst about regarding women's choices to have or not have children in terms of how it impacts their career, and she thinks this is an interesting conversation to have with younger women from different generation of being far more aware of the implication of motherhood for them.
Very interesting, and I wonder if whatever decision you make, obviously it's your decision, but unfortunately women who don't have children still have to face the stigmatization and the stereotyping, and often it is worse in some ways because as women hit their 30s, there's a very strong expectation that they're going to leave and have children, even if they say that that this isn't part of their plan. So they get discriminated against in leadership and recruitment decisions, even if they have made that decision themselves.
Thank you, Rebecca. We have one more question, which will be our last question. Then we move on to the next presenter. Is there any research on the potential positive outcomes for women in business post-menopause?
It's a fantastic question. And there's lots of really interesting work looking at women's decisions to move into entrepreneurial spaces at the time of menopause. So that's positive. I think you could argue that the reason why they move out of organisational employment situations is that they are not comfortable there anymore and they're not supported anymore. But there are some positives. Certainly, post-menopausal women's experience is somewhat positive. So there's some evidence to suggest that post-menopausal, so once women have really their symptoms have resolved from going through menopause, there is an increase in assertiveness, and they are perceived for a moment before they retire and they're not menopausal anymore and they're not seen as elderly. For a very short time they're actually seen as very as good candidates for leadership positions. So that split second, get in there. Yeah.
Thank you, Rebecca. Please joining me too. Thanks. Thank you for the great presentation.